Good evening, everyone. Welcome to the CSRS Education Society's webinar on technologies in the cervical spine. Our new platform is making surgery safer and more efficient. We'd like to thank all the participants for attending this very informative and interesting webinar. Our speakers tonight will be Dr. Michael McCarthy, Dr. Venu Nemani, and Dr. Shiraz Qureshi. We'll be moderating Dr. Samuel Cho and myself, Dr. Sanjeev Sarotwal. As part of the CSRS, we'd like to encourage you to save the date for our next annual meeting, the 53rd annual meeting and 30th instructional course in Washington, D.C. This year will be held from December 3rd to the 6th at the Westin, Washington, D.C. downtown. We look forward to seeing many of you there. And for those who are not members of the CSRS, we encourage you to apply for membership. Membership applications are open from May 1st to September 15, 2025. And you can look online for further instructions. You can also connect with the CSRS on our social media platforms on LinkedIn, Instagram, X, and Facebook. Tonight's talk will be recorded and be available for future viewing under the webinars section of the CSRS YouTube channel. We also have cadaveric technique videos as well as topical presentations. We encourage you to look up the CSRS YouTube channel for further talks. For tonight's presentation, we will have the three different speakers talk about the various topics here, and we'll have a live discussion at the end, which we find very informative.
And next will be by Dr. Venu Nemani from Washington State, and he'll be giving us a talk on augmented reality, 3D printed guides, and related technologies.
All right. As someone who's also from the great state of Indiana, I will also say go Pacers. So yeah, hopefully they turn up. So great introduction to navigation by Dr. McCarthy. So I'm going to talk to you about some of the newer kinds of navigation systems that have come available over the last several years, and some that are maybe a little bit less utilized. And I just want to thank the CSRS for giving me the opportunity to talk about this with you all. So these are my disclosures. I do do some consulting for Mighty Oak Medical, which is one of the makers of 3D guides, as well as for Orthofix, which makes one of the light-based navigation systems that I'm going to talk about tonight. And then a couple disclaimers. I do typically still prefer freehand technique for the vast majority of instrumentation placement in the cervical and upper thoracic spine. And this is for some of the reasons that Dr. McCarthy talked about, which I'll also get into a little bit later. And then all of my posterior cervical fusions, I still do open. And so my experience I'll talk about here is really as it pertains to open surgery and not related to any sort of MIS fixation of the posterior cervical spine, which I, as of yet, do not do. So as Dr. McCarthy talked about, why might we use navigation in the cervical spine? This is just a schematic. When we think about the typical types of fixation that we often utilize in the cervical spine, especially in the subaxial cervical spine, these are often lateral mass screws, and these are quite safe screws to place by a freehand technique because we're going medial to lateral, and we're kind of aiming away from danger, right? We're aiming away from the spinal cord, we're aiming away from the vertebral arteries. However, with more advanced types of fixation techniques, such as using subaxial cervical pedicle screws, which we may want to utilize for certain situations, these can be somewhat difficult. They're often small and cortical, and there is danger both medially and laterally with the vertebral artery laterally and spinal cord and nerve roots medially. Other reasons why we might want to use navigation is from distorted anatomy, either from prior surgery or from spinal deformity. And then, as Dr. McCarthy had brought up, it might decrease the stress in surgery because it can simplify to some extent the placement of instrumentation in otherwise challenging anatomic situations, as well as I also agree that for training residents and fellows, the real-time feedback is really fantastic. However, motion can cause navigation errors, and there is the potential for time loss and workflow disruption to using navigation. Now, depending on the situation, the net benefit of using navigation might be helpful. However, in other situations, the net benefit might not favor navigation, and you might want to use freehand technique depending on the resources and efficiency with using freehand technique. And I think the more complex the operation, obviously, the more important it is to get through the case efficiently. And so this was a C2 to pelvis that I did, where the navigation tools we were planning to use all did not work. This included a mix of 3D printed guides and stealth, and we had some errors due to registration because of loss of normal anatomic landmarks. And so we ended up using all freehand technique for this case, which enabled us to get through it and have a good result. So the modalities I'm going to talk to you about tonight are light-based navigation and registration, 3D printed guides, which is a technology that's been utilized a fair bit in the thoracolumbar spine, but is a little bit newer in the cervical spine, as well as some augmented reality tools that also can be useful for navigation. So first we'll talk about light-based registration and navigation. So this allows the registration of spinal anatomy using a visual light spectrum camera that basically takes a photograph of the spine in the operating room. And this analyzes the surface topography and then syncs this data to a preoperative CT scan to essentially localize the spinal anatomy and allow you to perform navigation. The benefit of this technology is that it uses segmental registration. And so, as Dr. McCarthy pointed out in his talk, one of the issues in the cervical spine is that it's quite mobile. And so without segmental registration, you can certainly have navigation errors in a flexible cervical spine. The other benefit of a technology like this is that you can actually move the array without having to perform a re-registration, because again, you're just taking a picture in the operating room. And so this allows quick movement of a reference array if necessary. If it's being blocked by the path of your instruments, all you need to do is just move the array and take another picture, and then you're ready to go again. And this also relies not on an intraoperative spin, but rather a preoperative CT scan. And so there is no imaging acquisition that's required in the operating room. And so there is a time savings in that manner. Just a case example of this. This is an 81-year-old woman that came into our hospital with central cord syndrome and acute neck pain after a fall. And she had an autofusion from C5 to C7, fairly severe stenosis from C2 to C4, as well as a C1 ring fracture. And so this is an example where we use light-based navigation to perform this operation. And so we were placing C1, C2, and C5 fixation. And you can see here the registration data that you get. Each of those green dots in the image is an individual pixel that is synced between the picture that's taken in the operating room and the CT scan that was obtained preoperatively. And then these are some of the images from the navigation itself. The nice thing is that even though C1 is in two pieces, you can separately register those and actually place fixation quite readily. Same thing with C2, where there are relatively close high-riding vertebral arteries, and we place subaxial cervical pedicle screws at C5, and you can see the tracks that we created there. And so this is the final intraoperative construct with C1 lateral mass screws, C2 pars / pedicle screws, and C5 subaxial pedicle screws. We obtained a postoperative CT on her, and so you can see the accurate placement of all the instrumentation. And I've marked the location of danger in red there, the vertebral arteries. You can see that we are able to place, using this type of navigation, screws into tight spots with a great deal of accuracy. There are some limitations to this technology. So you do need a preoperative high resolution fine cut CT. This just does not work as well with an intraoperative scan, although it can be done, but the fidelity is just not quite as good as a real CT scan. Additionally, the landmarks for light-based registration can be obscured by blood and scar tissue. And so this can affect the quality of the image that you obtain and how well it actually syncs to your anatomy. And there are no large series as of yet describing the accuracy of this technology in the cervical spine, although there have been some case reports published. Another technology which can be useful is the use of 3D printed guides. This is something that I think less people are familiar with. And what these are is essentially a CT scan that is turned into a three-dimensional model of the spine. And then using that 3D model, you can generate 3D printed guides that directly fit on the posterior elements of the spine with drill channels that essentially can be utilized to create a predetermined drill tract into the pedicle or another bony channel in the spine to assist with placement of instrumentation. So these are both patient-specific and level-specific, and this is an example of a plan that's generated for a particular patient. And the nice thing is that there is little to no change in a typical open surgery workflow. There's no need for an intraoperative spin. There's no reference arrays or any of those things. And you can see there's no C-arm in there either, right? And so all it is the guide that is placed down on the prepared posterior spine. This is a use, me with my fellow doing a scoliosis case. And so it's quite nice from that standpoint. And these are available from several different companies, and there are also surgeons around the world that are self-printing these as well for use. You can see there are a few thoracolumbar deformities in there, as well as a cervical model down at the bottom. We did a study of this looking at our experience. We've used this for over 6 years now for thoracolumbar reconstruction. And so we did a study looking at our experience of placing over 2,000 screws in adult spinal deformity reconstruction cases, and these were all thoracolumbar cases. And we found a 99.5% accuracy rate assessed by postoperative CT scan with 0 spinal cord injuries or vascular injuries. And so this is definitely safe in the thoracolumbar spine. A recent study by one of the Italian groups did look at this in the cervical spine with patient-specific 3D printed guides, and they found a 93% accuracy rate for placement of cervical pedicle screws. Importantly, the breaches, the majority of them were lateral, which is obviously concerning in terms of risk for a vascular injury with injury to the vertebral artery. However, there were no neurovascular injuries in this series that they reported. The limitations of the guides are that the guides can be bulky depending on their design and can be difficult to seat perfectly on the spine, especially in large patients with deep wounds. And there may be additional time that's necessary for dissection to completely clear off the soft tissue so that the guide can have a very solid fit on the posterior elements of the spine. Last technology I'm going to talk about is augmented reality. And so this is something that was developed to address the issue with navigation of the fact that typically when we're using navigation, we are staring at a screen or an external monitor rather than looking down towards the patient. And augmented reality systems allow for what I call a heads down display, where the navigation info is projected onto or near the operative field via either goggles or a headset, so that the navigation information that you're utilizing is projected in a place which is also where you're looking down at the patient. And so the nice thing about this is that you're not having to look up. There's an ergonomic benefit to it, and there's a melding of the information that you get both from the tactile and visual feedback of the actual patient's anatomy. And this is true both in open and MIS surgery, although it does shine a little bit more in MIS surgery in its current iteration, but allows you to meld the open bony anatomic landmarks that you see from open surgery, as well as the more detailed axial and sagittal information that you get from navigation. In MIS cases, there's also a virtual 3D model that can be visualized under skin, which makes it feel like you're doing open surgery, but in an MIS setting. And this also can be helpful. As I mentioned at the beginning, I've not done this in the cervical spine via MIS fixation techniques, but I have done it frequently in the thoracic and lumbar spine. And the tactile feedback helps with merging that with the 3D model visualization. There's very little data on the use of this in the cervical spine as from a data standpoint, and so this is still in a nascent technology. I want to finish up by showing a case, and this is actually a case that resulted in a complication with use of navigation, which is why I want to show it. This is a 64-year-old gentleman with a prior ACDF 10 years ago from C5 to C7. He initially did well, but then developed severe neck pain and subsidence, which was treated in a collar. And his current symptoms are neck pain, dysphagia, and difficulty holding his head up with recurrent myelopathy. The zoomed-in images of the cervical spine shows multi-level subsidence with fracture of C5, C6, and C7, with the plate essentially completely dislodged from the anterior cervical spine. MRI shows stenosis with some tenting of the spinal cord over the apex of that kyphosis, and you can again see that plate essentially dislodged from the cervical spine on the sagittal CT scan. There were several challenges with this patient. He was quite a large patient with a very short neck. This is a revision surgical approach as he had had prior surgery. He had high riding vertebral arteries bilaterally at C2. I wanted robust fixation, again, given the kyphosis and multi-level fractures and failure that this patient had previously and given his size. And so from a surgical plan standpoint, we plan to do a posterior fusion from C2 to T2 using instrumentation placed using 3D printed guides to place multiple short subaxial pedicle screws, given the second stage plan of a multi-level corpectomy. So we did not want our screws to extend into the body. And then removal of those ACDF cages and reconstruction in the front. This is the surgical plan that we got from for placing our screws using 3D printed guides. Intraoperatively, the posterior wound was quite deep as well as stiff, and so this made accurate guide fit difficult and unreliable. You can see the depth of that guide is essentially completely buried within the wound. And so we actually abandoned this intraoperatively, and we switched to using augmented reality-based navigation for the placement of screws. In this case, I used a 2mm burr to cannulate the pedicles, given that there's very little deflection of the anatomy using a burr rather than a drill or a gear shift, because anytime you're pushing with navigation, you're moving the anatomy, and what you see on the navigation screen is no longer a reliable representation of where the anatomy is. And the nice thing is a 2mm burr is not much bigger than the end of a ball tip probe, so you can cannulate quite small pedicles with this. And then you can always complete the cannulation if necessary using an awl or a tap. For augmented reality, and alternative workflows actually have only your assistant wear the headset. So you can see here, I'm actually not wearing the headset. I'm looking at the screen, and my assistant is wearing the headset. So I can easily see the open anatomy using my loops and my regular light visualization, where my assistant has line of sight onto the reference array, so there's no line of sight issues. This case was going well. We placed left side of pedicle screws from C3 to C7, but during cannulation of the left C2 pedicle with a high riding vert where we were trying to get a long screw in, I injured the left vertebral artery. I consulted one of my neurovascular colleagues and I completed the posterior portion of the case, placed a short screw, and we actually did an intraoperative angiogram, which showed a small pseudoaneurysm, which ultimately later, 4 months down the line, underwent flow diverting stent placement. He was neurologically normal. And so in this case, I think one of the limitations that happened was my reference array was on T1, perhaps too far away from C2 for navigation to continue to be accurate. And so this is something to be aware of with a mobile cervical spine. I think also one of the limitations of navigation in general is there's a tendency to trust the nav inherently, just like you would trust Google Maps if you're getting directions to a place you don't know, but you ignore the detour signs telling you to go elsewhere. So I think you always need to be aware of the tactile and visual feedback you're getting from the anatomy and trust that as well, in addition to using your navigation as a guide. So in summary, there's a lot of new technology available to help us perform cervical spine surgery safely, but you need to know the limitations of each technology and when to bail, and build in redundancies when trying new things. This is us using cervical pedicle screw guides for the first time, and also using stealth navigation to confirm our landmarks and tracks when trying new technology and techniques. Thank you.
Thank you, Shiraz, and I'd like to thank all three speakers for their outstanding talks on emerging technologies in the cervical spine. Now the session is open for Q&A. If you have any questions, please type it in the chat box, and we'll try to address some of them. And by way of starting, I'm going to ask all three speakers on the topic that they actually had covered, and that is the mobility of the cervical spine. The number one question is, how do you stabilize the cervical spine when you're positioning it? And number two, intra-op, I think Dr. Nemani had mentioned he likes to use the burr instead of pushing on the cervical spine because of the mobility issue. How do you deal with that? So how do you immobilize the cervical spine? You use
Sam, I could start there. It's
Yeah.
specific to me, and I'm sure Mike and Venu and others have their own ways, but I, instead of using a Mayfield or Gardner Wells tongs, I'll use a face positioner. similar to what you might think of somebody, a face holder that you might use in the when you're doing a lumbar case. I do find that that results in even more stability of the cervical segment than a Mayfield does. And then I am pretty liberal, even if I'm working with navigation or through a robotic arm with the use of fluoroscopy. I think it's a great place where you want to sort of use everything in your armamentarium as far as imaging goes to ensure that you have accuracy. And I haven't yet done robotically placed percutaneous pedicles, screw fixation in the cervical spine. Waiting to take the leap on that one, but at least in an open case, I'll still have the C-arm sort of draped in, and then have the face and the neck in a face holder, tape on the head, so that you get as much stability as possible. But even with that, there can be movement. What I find is that setting the trajectory and the starting point sometimes can be of greatest benefit, and then just kind of staying within those angles. But it's something that you need to be cognizant of the entire time.
Yeah, so I also do something similar. I don't use the face pillow, which is a good idea, but I also use a Mayfield. I think for some of the technologies where you have to register to an intraoperative CT scan and then you rely on the frame not moving the entire case, I think it's super important. One of the potential benefits from some of the other technologies that I talked about is there's less of that reliance on not bumping the frame or movement, because you can just re-register very, very quickly. I think also with 3D printed guides, for example, again, because they're segmentally based and they sit on the posterior elements of a single vertebrae, then there is no chance for shifting. However, one unique thing that can be an issue there is if you position the spine in lordosis, or meaning an extension, like you might in a Mayfield, if you want to just set the alignment before you start, the guide can actually have interference from the adjacent facet joints because they're shingled, or even the adjacent spinous processes. Because the design of the guide is based on their position in a CT scanner, and sometimes you might have the head, with a bump behind it or something like that. So you have to be mindful of that. So there are some nuances from a positioning standpoint that can play a role in this. If I'm using 3D printed guides, I actually usually position the spine in Gardner-Wells tongs in flexion. That way there's less interference from the adjacent anatomy, and then I'll just use bivector traction and then place the spine into extension when I'm dropping my rods and locking in the final alignment.
The way I tend to think about it, Sam, is once that spin occurs, an intraoperative spin, it's kind of like a nuclear isotope. It's going to decay. How rapidly that decay is happening, it's difficult, but I think especially in the cervical spine, you have to be acutely aware of that. So I tend to think that as soon as I capture that, that's the most perfect information I'm going to have. It's all going to slowly become more and more inaccurate. So I will wherever I've clamped with, that's again typically C3 or C2, I then go and do my furthest segment away. So if I'm going to instrument T1 or do any cervical pedicle screws, I go furthest away and then work my way back up towards the reference array. Again, always thinking of time and distance as the enemy. So time from spin and then distance from array, right? Those are two things I always kind of beat into the fellow's head, is those are their enemies.
Thank you. Those are very useful answers and very helpful tips as well. Dr. Wilmer from Godoy thanks us for the excellent talk. And there's a question about changing alignment during the case to provide better lordosis. So, anyone want to?
Yeah, I could start there. I'm sure I use an old trick that I'll place a IV pressure bag under that same face pillow, and then right before, after all the instrumentation is in, I'll have somebody squeeze the bag, which allows, sort of this improvement or restoration of lordosis. Take an X-ray, see what that looks like, and then place the rods.
Yeah, I use so in a flexible spine, I think that placing the patient's placing the patient's head where you want it, getting an X-ray and making sure you're happy with it, I think works well. For some of the more severe deformities, I will often use Gardner-Wells tongs, or if you have it, a pneumatic Mayfield, where you actually have control of the head through the drapes, and then you can adjust the head position intraoperatively. Although realistically, sometimes it's a little hard unless you have the drape that comes with it. It's hard to grab the handles and actually adjust it. So I'll often have an assistant or one of our PAs or even a resident or fellow get under the table and manually manipulate the Mayfield and the patient's head while you bring the head up with the pneumatic head holder. And so there are some tricks there. The other things that you can do is intraoperatively, if the posterior elements are still intact or the spinous processes are still intact, you can use Atlas cables around the spinous processes. And as you tighten the Atlas cable, that will bring the spinous processes closer together. You can also use a penetrating towel clamp to essentially squeeze on the posterior elements, and that because it's a fair bit posterior from the center of rotation of that individual vertebral segment, that can also generate lordosis as you then tighten your set screws and lock down your rods segment by segment.
Great. Thank you very much. I think it's already 9:01, so this will bring us to the close of this webinar. So this will be uploaded in YouTube. So join the YouTube channel for CSRS, and then look out for the next webinar. Thank you, everyone.